Hypertension with bradycardia is where the blood pressure says, treat me, but the pulse says, choose carefully. The problem is not that the blood pressure becomes less dangerous. The problem is that some blood pressure drugs also slow the heart down. So if someone already has a pulse in the high 40s or low 50s, or has sinus node disease, PR prolongation, or conduction trouble, the wrong prescription can fix the pressure number while making the patient dizzy, weak, syncopal, or even more bradycardic. That is why this is really a prescribing phenotype. The smart move is to separate pressure-lowering drugs from rate-lowering drugs. If your goal is to lower pressure without crushing heart rate reserve, the cleanest options are usually amlodipine, Lisinopril, losartan, and sometimes indapamide. Amlodipine is often the star here because it relaxes artery walls without meaningfully slowing the sinus node. So in a patient with, say, a blood pressure of 158/96 and a pulse of 52, amlodipine 5 mg once daily often makes a lot more physiologic sense than reaching for a beta blocker. Lisinopril or losartan are also strong choices when you want to lower pressure by calming the renin-angiotensin system, especially if diabetes, kidney disease, albuminuria, or coronary disease are part of the picture. And if the patient looks salt-sensitive or older, indapamide can be useful because it lowers pressure without directly slowing the heart. Now look at the drugs that usually become awkward here. Bisoprolol, metoprolol, verapamil, diltiazem, and often clonidine. Why? Because they are not just pressure drugs. They are also heart rate drugs. And in a bradycardic patient, that can be exactly the wrong direction. So before treatment, you do not just check blood pressure, you check the pulse, the medication list, and the ECG. If the ECG shows simple asymptomatic sinus bradycardia, your treatment lane is usually straightforward. If it shows AV block, bifascicular disease, marked PR prolongation, or the patient has dizziness or syncope, that is no longer simple hypertension. That is a rhythm-aware case. So the memory line is this. In hypertension with bradycardia, do not slow an already slow heart just to improve the BP number. Choose vessel-active drugs, not node-suppressing ones.